Hello everyone, and I hope you're having a great day. My name is Lacey Bracken, and today I will be presenting on AED policies and procedures. When it comes to policies and procedures as athletic trainers, we have many of these, but sometimes we don't have specifically an AED policy and procedure within our emergency action plans and or our policies and procedures manual for our sports medicine department. I'll go over a couple of things that are very important when writing these procedures along with defining some terms and different things. So let's dive in. As a disclaimer, I have no financial interest or affiliation with any of the materials discussed within this presentation. There will be many different things referenced and utilized as resources within this presentation that will have appropriate citations that you can take pictures of for your reference to refer back to later on. In today's presentation, the learning objectives include defining sudden cardiac arrest, what an automatic external defibrillator is, and how to properly maintain this AED, depending on the model that you might have. I will also go through examining current AED policies and procedure standards throughout different settings. And then lastly, I will end with constructing an emergency action plan with step-by-step procedures for sudden cardiac arrest to be used as an example for healthcare providers and athletic trainers looking to create the AED policy and procedure within the setting they work in. To start, I want to define sudden cardiac arrest. Also in this presentation, you might see it as SCA. Sudden cardiac arrest is defined as the abrupt loss of heart function in a person who may or may not have been diagnosed with a heart disease or other heart conditions. This definition comes from the American Heart Association, and they also point out that sometimes sudden cardiac arrest can come on suddenly or in the wake of other symptoms. Sometimes personnel or patients that experience sudden cardiac arrest have previous symptoms as warning signs, or sometimes they're completely asymptomatic. According to the CDC, approximately 350,000 people experience an out-of-hospital cardiac arrest annually. Certain people, including people within lower income Black or Hispanic neighborhoods, are less likely to receive CPR by bystanders than people in high income white neighborhoods, according to the CDC. And the CDC also found that women might also be less likely to receive CPR if they experience cardiac arrest in a public place. The next definition I want to provide is for an automatic external defibrillator, or also known as an AED. Casa and colleagues in the textbook Preventing Sudden Death in Sport and Physical Activity define an automatic external defibrillator as a computerized device that analyzes a victim's rhythm, determines whether a shock is needed, charges to an appropriate shock dose, and uses audio and visual instructions to guide the rescuer through a step-by-step process during a sudden cardiac arrest emergency. These devices are easy to use and extremely accurate in recommending a shock only when necessary. In a study conducted by Gundry and colleagues, AEDs were found to be safe and successfully operated by untrained sixth graders almost as quickly as trained paramedics in a simulated resuscitation. The difference between the two groups was only a 23-second difference in the mean time to defibrillation for the simulated resuscitation exercise. To help support the use and access to automatic external defibrillators during sudden cardiac arrest, the CDC established the Public Access Defibrillation Program, also known as PAD, in 2017. This program and policies works to ensure that AEDs are immediately available for the use by lay bystanders when they are needed. This includes having AEDs in locations, including but not limited to airports, schools, churches, casinos, and sporting facilities. To increase the outside of hospital cardiac care survival rates, public access defibrillation programs can use interventions that ensure AEDs are immediately available when needed. In this program, the study that they use examined the extent of the state laws, and they come up with 13 types of PAD interventions that could be potentially used to increase the chance of survival during a sudden cardiac arrest event. Of the 13 interventions, 3 were ranked best, and 4 ranked promising in evidence-based ratings according to the 2017 PAD Policy Evidence Assessment Report. The 7 PAD interventions to enhance state laws that they came up with that were based on evidence ratings included targeted AED site placement, training anticipated responders, including PAD coordinated with emergency medical services, including an emergency response plan, including a routine maintenance and testing of AEDs, including an ongoing PAD quality improvement and quality assurance monitoring, and then limiting liability for the people that could potentially be responding with the use of an AED during a cardiac emergency. This specific program is specifically more for the lay bystander and not specifically healthcare providers, but this can be a program to help reinforce you writing within your policies and procedures or getting state legislation to move the needle to make changes in regards to AED policies and procedures and requirements. As this PAD program has been enacted, there has been a little growth, even though there hasn't been much. The state laws do continue to vary, and there does seem to be continual movement in the right direction with AED policies and procedures. This will continue to leave room for improvement within the state laws for AED requirements and hopefully potentially requiring AEDs and policies and procedures to be in place at every school, every setting, and every venue possible so that sudden cardiac arrest can be treated promptly and rapidly with appropriate techniques. AEDs used by athletic trainers typically come in a portable version. There are a couple of different brands of AEDs that you might see on the sideline with a certified athletic trainer. These AED brands include Cardiac Science, Zoll, Defib Tech, LifePak, Philips, and HeartSign. Even though there are many different brands of AEDs, as mentioned previously, every portable AED has regular maintenance required. Each model has its own specific owner's manual that should be referenced to determine if there's any specific maintenance required for the unit that you have. In general, all AEDs require regular maintenance to include the following. All AED batteries should be checked monthly, and when the batteries begin to get low, most models will make a chirping sound like a fire detector or have a light that turns from green to red. All AED electrodes also need to be checked monthly, and these AED pads do typically come with an expiration date, which can be used as a reference for when the pads need to be replaced. But sometimes the AED pads have been tampered with and also need to be replaced, so it's important that they're also checked for security purposes. An AED should also be checked monthly to ensure that the unit turns on when either the unit is powered on by pushing the power button or that the unit powers on when opened. Each month, it's also important to ensure that the quote-unquote AED kit is stocked and includes the following: electrodes and pads for child and adults, a CPR mask, gloves, scissors, a razor, a towel, an antiperspirant if appropriate to help reduce sweating and help pad adherence, and or antimicrobial wipes. In general, any maintenance performed on an AED should be documented. This can be documented in a regular maintenance log that's kept within the sports medicine department to be referenced in the event of an emergency or just to know as things go along in the busy school years to make sure things are getting done in due time. We as athletic trainers know within our settings we have monthly, weekly, and annual checks that have to be done, and this just needs to fall in line with all the other checklists that we have and the things that we're doing to make sure that we are following best practices and policies and procedures appropriate that we have written. Now that definitions have been established on what sudden cardiac arrest is, along with what an AED is and how to provide proper maintenance for the AED that you might have, I want to go through some of the recent literature in regards to AEDs, emergency action plans, and then specifically AED policies and procedures. Throughout this literature, we will look at different settings along with different resources that can be used for healthcare providers when writing an AED policy and procedure. Vascular care by setting is going to have some differences based on the governing bodies. First, looking at the secondary school setting, the study performed by Scarnio Miller and colleagues examined the presence of state-level implementation of health and safety policies at the secondary school level. The subsections of the state grading rubric that they used examined the leading cause of sudden death within the secondary school athletics, and this included sudden cardiac arrest, exertional heat stroke, and traumatic head injuries. The rubric also included appropriate healthcare coverage and emergency preparedness. This study was originally conducted in 2017 with an update performed in 2021. 2017 study, Scram Miller and colleagues found that states only met 23% to 78.75% of evidence-based best practice recommendations, whereas in 2021, the states had a slight increase to 30.8% to 85% depending on the state. Many of the states with the lower scores were typically lacking policies in one or more of the subsections altogether. And once again, this did vary state to state among the secondary school setting. At the secondary school level, policy implementation had a large variability due to the differences between each state's procedures for developing and implementing health and safety policies. Each state has the autonomy to develop and implement procedures, which is voted on by each state's high school athletic association after receiving recommendations from its Sports Medicine Advisory Committee or enacted through state legislation. The researchers found that ultimately to optimize the health and safety of the secondary school athletes, policies and procedures to minimize the risk of sudden death and catastrophic injury need to be created, implemented, evaluated, and refined by the Sports Medicine Advisory Committee within each state and not the High School Athletic Association. This allows the states to lean on its medical providers and the experts within the fields to help conduct and write this legislation and these policies and procedures for them within their state. Provided from the study outlines evidence-based best practice recommendations endorsed by medical and sports organizations that can be used as resources when writing policies and procedures for the secondary school setting. The red box shows the resources specifically for sudden cardiac arrest. Study to review is a systematic review conducted by Hedberg and colleagues. The purpose of this systematic review was to identify compliance to emergency action plan recommendations, access to an athletic trainer, access to an automatic external defibrillator, and current legislative mandates in school-based athletics. From this study, they found a wide range of EAP adoption and a low rate of compliance to EAP guidelines among the U.S. schools that they observed in this study. They did find that barriers to EAP adoption and compliance were not well documented across all of the studies, but when it comes to EAP recommendations, they did find that it should include having an EAP in writing and that they should be distributed to all appropriate personnel. They should ensure that they incorporate and work with their local emergency medical services and rehearse this at least annually. When looking at AED availability within the schools, they found that only 48% to 98% of all schools in each state, depending on the state, had an AED available in the event of an emergency. When looking at the AED availability at all athletic venues by state, only 61% to 94.4% had an AED available on site. Also within this systematic review, when looking at school-based athletics, specifically in regards to the AED availability recommendations, the American Heart Association recommended that state laws and regulations require schools to have a cardiac emergency response plan, and this should include the availability of an AED. From this study, they found that only 17 of the 50 states had some type of legislation that required AED installation at the schools. That's only 34% of schools within the states. The study also showed that only 4 of the 51 state high school athletic association member schools within those states were required to meet best practices standards for EAP adoption, and only 7 of the 51 were required to meet best practices for AED access. When we look at the state high school athletic association member schools, this does include mostly public schools, which limits and takes out the private schools, which is a whole nother area of data that can be explored. Within this systematic review, some of the common barriers found included document like that it was for limited access to AEDs that was documented included lack of funding, medical legal reasons, for example, fear of liability and or lack of certified medical personnel within the school-based athletic settings as provided within the systematic review. Setting of focus is the collegiate setting. The consensus statement provided by Hanlon and colleagues summarized the task force deliberations and includes available evidence on cardiovascular risk, pre-participation evaluation, and the recognition and response to cardiac arrest. For the NCAA member institutions, best practices for management of cardiovascular care include a cardiac evaluation. The evaluation, at minimum, includes a pre-participation evaluation of the student athletes to include a comprehensive personal and family history and a physical examination, such as American Heart Association 14-point evaluation or the pre-participation physical examination monograph. If an ECG is included in addition to the history and physical screening, best practices are outlined by the NCAA in the Cardiac Care Best Practices document. Furthermore, the best practices for the NCAA institution also includes having an EAP for cardiac arrest and other cardiac emergencies. This includes a written EAP for treatment of cardiac arrest in place, reviewed, and rehearsed with all key stakeholders regularly. According to the consensus statement, the EAP should address each of the following: all trained, certified CPR and AED personnel, an appropriate communication system, locations of AEDs near all high-risk venues, clear and visible signage of all AED locations, open access to all AEDs so that they are not behind locked doors, and predetermined EMS entry and exit within all venues within the collegiate setting where sports and activities are being conducted. For the collegiate setting, in 2021, the American College of Sports Medicine presented a call to action. In this call to action, Thompson and colleagues recommended that AED should be present in all educational facilities and athletic events. They found that among all 50 states, AED laws addressing the attributes of a public access defibrillation program, also known as PAD, were in place. In recent years, several states have enacted statutes that require the placement of AEDs in fitness and sports facilities and at school athletic events. These statutes have provided definitions, requirements, and certain immunity provisions for protected individuals. As reiterated in research, to help ensure an AED protocol is developed and implemented, they recommended that facility event personnel should consult with a knowledgeable lawyer who can research current and applicable AED state statutes, or a healthcare provider with expertise in emergency medicine, along with following AED standards, guidelines, and position articles published by professional organizations. All of these resources should be used to help ensure that a proper AED protocol is developed and implemented at all of these facilities, including educational facilities and all athletic events. Outside of the secondary school setting and the collegiate setting, we also have master athletes. The next study, conducted by Young and colleagues, looked at cardiovascular care among master athletes. These athletes are categorized as being 35 years or older, and they're responsible for the vast majority of sports-related sudden cardiac deaths. Of the 68% that completed the survey within this study, they found that 38% of them were aware of where an AED was in a proximity to where they exercised. 40% were aware of an AED being available during their competitions, and 28% were aware of an AED being available during training events. What was interesting that they found only 10% were aware of an emergency action plan active in their place of exercise, while also half of the athletes perceived their risk of cardiac arrest during exercise to be equal to or less than 0.5 in a 1,000 person population. From this study, Young and colleagues concluded that all the athletes believed that CPR and AED was effective in saving a life, but the minority were aware of where the AED was in their place of exercise, and then even fewer were aware of an active emergency action plan. From this study, it can be seen that master athletes underestimate their own risk of exercise-related cardiac events, which yields the chance for even more education to this population to make sure that they are prepared in the event of a cardiac emergency. Now that we have an understanding of some of the current literature, let's go through what an AED policy and procedure should consist of. Policies, processes, and procedures are a part of an operational plan within a sports medicine department. To look at a few definitions, first, policy is defined by Cassiter as a plan for expressing the organization's intended behavior related to a specific program subfunction. In management strategies and athletic training, Ray and colleagues explain that policies are not intended to answer detailed questions about how the sports medicine program should operate. Rather, policies are intended as a roadmap to guide athletic trainers in developing and operating a sports medicine program in accordance with the desires of the policy board. Along with policy, we also have processes. Processes are defined by Ray and colleagues as the incremental or mutually dependent steps that direct the most important task of the sports medicine program. Each process should relate to at least one or possibly many of the policies that govern within the program. And lastly, procedures are defined by Ray and colleagues as specific interpretations of processes for athletic trainers and other members of the sports medicine team. So one might ask, why do we need an AED policy? An AED policy is needed because sudden cardiac arrest is the leading cause of death in exercising young athletes, according to CASA and colleagues. It has been found also by Thompson and colleagues that cardiovascular conditions cause 75% of deaths that occur during sports. AED policy is also critical because without the use of an AED with CPR, the rate of survival falls 7 to 10% for each minute that CPR is not performed. According to the Corey Stringer Institute, the use of an AED with CPR is the gold standard for sudden cardiac arrest, commotio cordis, and other cardiac emergencies that might occur. To go with the AED policy, we should also have an AED procedures. This will provide a step-by-step guide in the course of action when necessary. AED procedures should include prevention strategies, recognition techniques, and emergency action plan management. These procedures should be reviewed annually and rehearsed often. Anytime these procedures are reviewed and or rehearsed by the sports medicine team, the athletic trainer should document the completed training in a safety training log to maintain appropriate documentation and have reference of when these trainings have been completed. The AED procedures, one of the first things to be addressed should be prevention. When looking at prevention of sudden cardiac death, this includes a pre-participation screenings. Some screenings, even though they are the best protocol that we have, are highly debated and lack some accuracy. So this is not always the golden rule to prevent all sudden cardiac death. Sometimes as many as 80% of patients that have sudden cardiac arrest are asymptomatic until sudden cardiac arrest occurs, according to CASA and colleagues. Detection of asymptomatic conditions should be improved with standardized health history forms, attention to episodes of exertional syncope and presyncope, including chest pain, a personal or family history of sudden cardiac arrest, exercise tolerance, selective use of ECGs in high-risk athletes, and a stronger knowledge base for healthcare professionals. One tool the American Heart Association has released is a helpful 14-point pre-participation cardiovascular screen for competitive athletes. This tool is based on medical history and physical examination. This tool is simply a tool in an athletic trainer's toolbox to help detect sudden cardiac death predisposing factors. Other testing, such as an ECG, has been shown to help provide high measures when identifying a cardiovascular disorder associated with sudden cardiac death. If accessible to your setting, an ECG should be used to detect these predisposing factors. But once again, just because all prevention measures are taken doesn't mean that sudden cardiac arrest won't occur. This is why it is crucial to be prepared in the event of a cardiac emergency with an AED policies and procedures. When looking at a young athletic population, there are different causes of potential sudden cardiac death or sudden cardiac arrest. These differential diagnoses can fall under three different areas, and that includes electrical abnormalities, structural or functional abnormalities, or other abnormalities as listed by CASA and colleagues. Structural and functional causes of sudden cardiac death in young athletes include hypertrophic cardiomyopathy, coronary artery abnormalities, aortic rupture or Marfan syndrome, dilated cardiomyopathy, myocarditis, left ventricular outflow tract obstruction, mitral valve prolapse, coronary artery atherosclerosis, arrhythmogenic right ventricular cardiomyopathy, or postoperative congenital heart disease. Electrical causes of sudden cardiac death or sudden cardiac arrest in young athletes includes long QT syndrome, Wolff-Parkinson's-White syndrome, Brugada syndrome, catecholaminergic polymorphic ventricular tachycardia, short QT syndrome, or complete heart block. Other potential causes of sudden cardiac death or sudden cardiac arrest in young athletes outlined by CASA and colleagues were drugs and stimulants, commotio cordis, and primary pulmonary hypertension. Not only are our younger athletes at risk for sudden cardiac death, but also our older athletes are. In our older athletes, they are at risk for all the same sudden cardiac death causes as the younger athletes, with one addition. In older adults, exercise-related sudden cardiac death is higher because of the increased prevalence of ocular coronary artery disease. Cardiovascular disease risk factors or coronary artery disease risk factors for our older athletes include age, family history, history of smoking, the type of lifestyle they have, if they are obese, if they have hypertension, if they have dyslipidemia, if they are pre-diabetic, and if they have high cholesterol. All of these factors are outlined by CASA and colleagues in the Preventing Sudden Death in Sports and Physical Activities book. In the textbook Preventing Sudden Death in Sports and Physical Activity, CASA and colleagues provide 7 strategies from the American Heart Association to prevent sudden cardiac death in adult athletes. And these are the 7 steps they recommend. First, perform physical pre-participation screening history and physical examination using an appropriate questionnaire. Second, perform exercise stress testing and other appropriate cardiac investigations in selected healthy subjects based on risk factors and physical exam findings. Third, risk stratify using left ventricular functional assessment and exercise stress testing in athletes with known coronary artery disease, and recommend appropriate exercise restrictions based on the risk assessment in these subjects. Fourth, educate athletes and trainers on reporting possible predominant symptoms suggested of coronary artery disease. 5. Prepare fitness centers with external cardiac defibrillators and staff trained in CPR. 6. Gradually increase the physical training program for individuals who are relatively physically inactive rather than using the sudden or strenuous onset. And 7. Avoid unaccustomed physical activity, especially in extreme environmental conditions such as heat, cold, and high altitude. Step of the procedures to be prepared is an emergency action plan that's specifically for a cardiac emergency. This plan should include a list of personnel with CPR AED training that are on site and that is also venue specific. In the emergency action plans, means of communication need to be listed along with all AED locations. The AED should not be placed behind locked doors and should have open access to all individuals. The emergency action plan should be reviewed and rehearsed often, with these trainings being documented in a training log. Within the emergency action plan, the athletic trainer should have listed the closest advanced cardiac care facility and/or emergency department depending on what is available to you in your area. After a cardiac emergency occurs, all stakeholders should have a meeting and be involved to sit down to reset, debrief the situation, and report findings that need to be addressed. This will allow conductive communication and collaboration with all stakeholders to best improve the emergency action plan if needed at that time. Within the settings we work in as certified athletic trainers, if we have a patient go down with no known mechanism of injury, sudden cardiac arrest should be one of the first differential diagnoses. Sudden cardiac arrest is going to present with a sudden collapse, agonal or gasping respirations, and no pulse. Another potential differential diagnosis is commotio cordis. Commotio cordis is going to differ from sudden cardiac arrest in that commotio cordis symptoms include a direct blow to the chest, specifically over the left ventricle of the heart, and a sudden collapse. These injuries are typically seen in lacrosse or other sports that have high velocity movement. During the assessment, another differential diagnosis we need to have in our mind as athletic trainers is myocarditis or other post-COVID cardiac complications. Symptoms for cardiac concerns post-COVID include fainting or sudden loss of consciousness, chest pain, chest pressure or sharp pain in the heart or lungs, shortness of breath at rest or with exertion, increased in resting heart rate by 20 beats per minute or more, and palpitations, including heart racing, feeling of heart skipping, or dropping beats. For these patients that are post-COVID, a specific return to play protocol should be followed and precautions should be put in place to make sure that these athletes are returning to sports safely. A resource that can be utilized for these procedures is written by McKinney and colleagues in the Canadian Journal of Cardiology. They outline many of these things that can be included in this part of the procedures for our post-COVID cardiac symptoms and the patients that might be suffering from these symptoms. Assess the situation and determine that our patient is suffering from sudden cardiac arrest, we must move promptly. Treatment should include, according to the American Heart Association, they recommend a 5-part chain of survival for effective emergency cardiac care. And this includes immediate recognition and activation of EMS, which is what we will do within our emergency action plan, early CPR, rapid defibrillation with an AED when indicated, effective advanced life support, which will be performed by EMS, and then integrated post-cardiac arrest care. According to Thompson and colleagues, they found that if CPR is provided and defibrillation occurs within 3 to 5 minutes of collapse for our sudden cardiac arrest patients, that the chances of survival increase drastically. Just another infographic for reference on a universal response to a cardiac emergency response plan. When you have someone that is in sudden cardiac arrest, it is crucial and important to recognize, react, and rescue in an appropriate, timely manner. This picture here came from a video in partnership with the NFL that Dr. Denzer had produced when on the recognition and management of sudden cardiac arrest in athletes. Once again, emergency preparedness is crucial according to CASA and colleagues. Preparation is key to survival once sudden cardiac arrest has occurred. An athletic trainer should have in place the emergency action plan. This allows everyone in the situation to know what they are doing and the process that needs to occur to provide appropriate care. Now that we have reviewed parts of an emergency action plan and AED policies and procedures, let's review some of the organizational guidelines and resources available to write these documents. When creating the AED policies and procedures, there are some organizational guidelines that can be referenced. These could fall under 4 different categories. These include your state's Sports Medicine Advisory Committee, State High School Athletic Association, your setting-specific guidelines such as the NCAA collegiate setting, and/or your state's legislation. So far, the American Heart Association recommends that state laws and regulations require schools to have a cardiac emergency response plan, including the availability of an AED. But as stated previously, only 17 out of the 50 states have some type of legislation that require AED installation at all schools. This is why it's so important to look at all the guidelines from organizations within your state. With all states not having requirements but recommendations, the State Sports Medicine Advisory Committee are a driving force for implementing the Cardiac Emergency Action Plan recommendations. Hedberg and colleagues in 2021 found that once again, only 4 of the 51 State High School Athletic Association member schools were required to meet these best practices for EAP adoption, and only 7 of the 51 states were required to meet the AED access at the secondary school level. If more guidelines are needed outside of what is provided by some of your secondary school sports medicine advisory committees, high school athletic associations, collegiate setting guidelines, or other professions guidelines, we can also look at our state legislation as mentioned previously. This link here is an easy resource that I found to help reference what the state legislation is per state. It gives an outline of each state, and it also allows you to click on the law so that you can actually go read it on your state's website. Within this can be used to create the AED policies and procedures as you look to have information that backs up what you are putting within your policies and procedures. And at any time, if you are looking to make sure that you are providing right and sound information within your policies and procedures, you can always consult an expert in the field in regards to sports medicine education, along with sports medicine emergency care, and/or possibly a lawyer if needed in the event that you want to double check and cross check all of the information that you're providing within any of your policies and procedures, depending on your setting. With appropriate guidelines and resources, an AED policy can now be written. Now I will provide a few examples of what these policies and procedures could look like and the headings of the content within the document. This document pictured here was created by Higgins and colleagues in 2017. This picture is a checklist of a sudden cardiac arrest policies and procedures that can be used by athletic trainers. With many resources available, athletic trainers should not be reinventing the wheel on what to include within these policies and procedures specifically. The NAT website does have many resources, and this document is one of them. Within this document, you can see that they have included the components of the cardiac policy, procedures for proper management, equipment required for rapid treatment, education and training information for member leaders and member coaches, and then what the return to participation protocol looks like for a young athlete. This checklist is directed more for a secondary school setting, but there's valuable information that can be applied to many settings outside of the secondary school setting. Another AED policy and procedure provided by the NATA is the UGA Automatic External Defibrillator Policies and Procedures from 2001. Within this document, the policies and procedures included the following points: medical necessity for the use of an AED, which presented the definition of sudden cardiac arrest, defibrillation, and what an AED was. Under this heading, explains the purpose of what the use of an AED is. They furthermore go to explain the explanation of an AED and what the AED is specifically going to do in the event of a sudden cardiac arrest emergency. After explaining what an AED does, within the UGA policies and procedures, they go into the written medical protocol regarding the use of an AED. This part of the policies and procedures provides the step-by-step process that the sports medicine team will follow whenever there's a cardiac emergency within their sports settings. After the written medical protocol regarding the use of the AED, they go through the provision to coordinate with local EMS. So they provide who's going to be calling EMS and how they're going to be communicating with EMS depending on their site location and who all is covering the practices and or athletic events that the UGA Sports Medicine Department serves. After that, they go through their operator considerations, and this is specific to the AED model that they had at their schools. Depending on the AED model, there's different steps to possibly opening the AED, placing the pads. Some AEDs have a push button, or some will automatically deliver a shock. Within this operator considerations, they also outlined who could operate the AED. People who operate the AED need to be CPR and AED certified, and they include this information within the operator's consideration of the policies and procedure document, as can be seen at the link provided below. Also provided within this document was the medical control reporting and incident review. Within this portion of the document, they went over how the AED digitally recorded patient data, if it did so, how they would access the data depending on the model of the AED, and how an incident was to be documented per their policies and procedures. When it comes to these incident forms, sometimes the setting that you work in has specific incident forms for the university, the school, or the specific organization. These forms could be outside of what is specified within the sports medicine department, so could lead to a little bit more documentation on the part of the sports medicine team just to cover every basis within the HR department at the location where you're working. They also included the location and maintenance required for all of the AEDs. When they listed where the AEDs were, they were venue specific with exactly where the AED was located without leaving variable unknowns to where they possibly wouldn't be able to find the AEDs. Within the locations, they also outlined how many AEDs they had on campus or on site so that if there was ever any question of where the AED was, they knew exactly where it was. All of this information is not just for the athletic trainers, but every stakeholder that is involved within the sports medicine department, especially the locations of the AEDs. As athletic trainers, we know that we're not always at every single practice, event, and activity going on with our sports teams, so it's important that we prepare not only ourselves, but also all of our coaches, administrators, and every other stakeholder that might be involved within the processes of the athletics departments, depending on our setting. The last two things provided in the UGA Automatic External Defibrillator Policies and Procedures is the procedures for training and testing in the use of an AED. They included that the CPR AED training is required every 2 years for all athletic trainers and all of their sports medicine personnel as per our scope of practice and licensures and or certification. And then they also put within that part of the procedures how often their EAP review sessions would be. These review sessions, they also outlined how they would document them and maintain appropriate documentation throughout this entire process on the trainings. The last thing they included was the procedures to ensure the continued competency required for AED use. All of these things within this policies and procedures were reviewed annually and were to be documented as revisions were made. As an overview, it's important to remember that sudden cardiac arrest is one of the leading causes of death in sports. An AED policy and procedure is crucial to have to know what to do in the event of a cardiac emergency. An AED policies and procedures should always include prevention, recognition, and emergency action plan management strategies. When writing AED policies and procedures, it's important for different settings to remember the different organizational guidelines and resources that can be referenced. For the secondary school, these include the State Sports Medicine Advisory Committee and the State High School Athletic Association. For the collegiate setting, this could involve the division's setting guidelines based off of the division of the school. Within each state, there's different state legislations that can be referred to when writing AED policies and procedures. And then within different settings as athletic trainers, such as occupational settings or industrial settings, military settings, and other settings that athletic trainers are beginning to emerge in, it's important that you find what those guidelines are that you need to follow depending on that setting and also the resources available to you. When writing an AED policy and procedure, an athletic trainer should not be reinventing the wheel because there's many resources out there available for athletic trainers to use and reference when writing these policies. So I want to thank everyone for their time that they spent with me today going over the AED policies and procedures presentation. I can be reached by email as seen here on this slide any time of the day with any questions or conversations that want to be had in regards to athletic training, AED policies and procedures within our sports medicine departments. I hope everyone enjoyed the presentation and have a great rest of your day. Thank you.